begin.
We welcome
Dr. Bharat Sachdeva, and he's going to talk about
Drug-coated balloons and stents for AV access failure.
Yeah. So let's hear what he has to tell us about this.
All right, thank you, organizers, for giving me this opportunity again. I think we've seen this slide earlier on one of my earlier talks. Again, re-emphasizing that arteriovenous fistula being the best option, but has a very high failure rate, and often the dysfunctional AV fistula is subjected to angioplasty, and it tends to sometimes worsen the initial cause of that stenosis that was there. So let's kind of recap the histology again. A normal vein has smooth muscle cell, but the concentration and the composition of that is very different than in our chronic kidney disease patient veins taken at the time of fistula creation. There is much more thickening, much more aggressive growth of smooth muscle cells which tend to infiltrate into the intimal tissue, and that increased growth leads to inward revision of that access, which leads to lower luminal diameters. When a fistula is created, there is injury at the time of incision. The vein is cut, it is often handled, it's often moved from the position it's supposed to be at. Dr. Shenoy talked about a technique from France where instead of moving the vein, the surgeons actually move the artery, trying to prevent that injury to the vein wall. Again, that has its own set of problems. But then, even after the fistula is created, that injury may cause some degree of smooth muscle proliferation, migration of myofibroblasts into that intimal tissue. And then there are hemodynamic factors that are constantly causing more neointimal hyperplasia, which leads to this stenotic segment. So think of it that stenosis is on the left, which is there. Now we go in with our angioplasty balloon, we try and open up that stenotic segment. Essentially what you're doing is you're doing an uncontrolled dissection of that vessel. The neointimal tissue dissects out, you get a much bigger wide lumen now, but over time the restenosis factors are going to come in, probably aggravated by the injury that we just caused, and the tissue is going to start healing back in, and sometimes the luminal size may even become smaller, and that has been shown eloquently in patients who have central vein stenosis, asymptomatic. You go in and you do angioplasty on those asymptomatic central veins. The results are actually worse in a few months. So the recurrence of stenosis is because of proliferation of injury proliferation of tissue after that angioplastic injury. There are some surgical factors that do that. Uremic milieu is responsible for that. Some mechanical factors are responsible for that. And then the constant shear stress in an AV fistula with turbulent flow can sometimes worsen that process as well. Now, when we talk about drug-coated balloons, I think most of the initial enthusiasm was taken in from the cardiology literature and the use of drug-coated technology in an arterial vein or arterial segment. And the plaque or the disease in an artery is very different than the disease in a vein. So we've got to keep that in mind when we look at this topic. The most of the atherosclerotic plaque is cell debris, lipid, with some inflammatory cells in there, whereas the intimal hyperplasia that is seen in a vein is usually a thick collagen matrix with a lot of smooth muscle cell proliferation. It's a little different disease. The intimal elastic tissue tends to be thinner in a vein. There are fibroblast growth factors. Sorry, went forward. And then the hemodynamic shear stress factors are very different in a vein as well because of the flow patterns are very different in a fistula than a vein. And then you have to remember that the veins are getting cannulated repeatedly, so there is an ongoing injury in that vessel on a constant basis. Now, over the years, we've kind of come a long way from the very first angioplasty back in 1977, the bare metal stents in 1988, and then the drug-eluting stents, which started coming out in 2002. And the outcomes in venous angioplasty and dialysis access have stayed unchanged pretty much over the last 15 years or so now. The primary patency can be sometimes as low as 50% in 6 months. And the KDOQI guidelines are right around that number, that we need to try and achieve a 6-month primary patency of 50%. So think of it. So you try and go to your car is bad and you take it to a shop and you say, you know what, I want it to be running in 6 months. That should not be the end point. I think we need to try and strive for better option. So what is drug coated is paclitaxel, which is a cytotoxic anti-cancer agent, and it arrests the mitotic cell cycle to prevent proliferation of cells in that area that you've just corrected, and hoping that if you do so, you will retard the growth of tissue back in that area which was causing that stenosis. So these are some images from patients who've got a bare metal stent without any drug coating on them, and you can see that the new intimal hyperplasia grows into that stent very aggressively. And over the years, by experience, we found that using bare metal stents in dialysis access is actually of no benefit at all. It's just as good as doing a PTA alone, and the tissue ingrowth is fairly aggressive and retards and decreases the luminal size fairly aggressively. So covered stent with the PTFE graft layer on top of that metal studs helps to prevent that ingrowth and has been shown to have some better results compared to the bare metal stent. So in my opinion, bare metal stents should never be used. When you use stents with drug coating, they've been shown to decrease that growth of new intimal tissue. But to date, there have not been any clinical trials done with drug-eluting stents in dialysis access. And I think that is an option that still needs to be explored and see if that is a viable option for our dialysis patients. The drug-coated balloons started coming into market almost a decade plus ago now in the cardiology world, and have been used in nephrology world for about 8 or 9 years now. And the application is essentially the same, where you open a lesion, you pre-dilate it with a conventional balloon, you open a balloon which has coated layer of paclitaxel, usually hidden with a carrier substance, which is urea. As you inflate the balloon, the urea is quickly dissolved, opening up the paclitaxel drug for the tissue to absorb. The drug is released by the balloon at this time. The loss of paclitaxel is a real problem sometimes. So if you leave the balloon open and it is not approximating to the wall of that vessel, a lot of that drug will be lost away. The idea is to make sure that you get good approximation. You leave the balloon up for at least a couple of minutes so that you can have that drug delivered to that area which you've just angioplastied, and the drug delivery starts within seconds. Usually by 2 minutes you've had the most of the drug delivered to that area, and histological studies have found that by retarding that regrowth, the amount of drug that is effective to prevent regrowth can be found in that vein that was angioplastied with the drug-coated balloon for as much as 180 days. So after delivery of drug today, there is still some amount of local drug presence at 180 days after that angioplasty. So the idea is really neat. So if you do this angioplasty and then you leave that drug there where you cause that injury, you should have minimal amount of new intimal growth in that area, so that one angioplasty should last you a much longer time. There are subtle differences in different balloons that are out in the market. When we compare the application of the drug and how it works, the stents tend to be a little more patchy in terms of drug delivery. There are certain areas where the drug is not growth, and there is some amount of growth that can occur through that area. But like I said, in dialysis world, there are no current studies that have used drug-coated stents to see what are the effects of that agent in that area. We do have drug eluting balloons available now in the United States up to the 12 millimeter. There is a Lutonix barred balloon that is the only drug-coated balloon that is approved for use in dialysis access. Prior to that, we've had several other balloons that have been used for arterial work that have been used in dialysis access as well. So if you look at some of the earlier studies, they were really encouraging. So if you look at this particular study where they used, again, an arterial balloon in a juxta-anastomotic area where the stenosis or the vein size is small. So a 4 millimeter balloon in that area had almost 100% primary patency at 90 days compared to, say, about a 50 to 60% primary patency when you did not use a drug-coated balloon. So really encouraging results, and even at 6 months, the drug-coated balloon only had 20% recurrence, whereas the conventional angioplasty was nearly 100% recurrence within 6 months of angioplasty. So since then, there have been a number of small center studies, some retrospective, some kind of case control studies, and a meta-analysis showed that there was some benefit of using drug-coated balloon in dialysis access. So that led to the first randomized control trial on a large scale where they included almost 200 plus patients, and the goal was to try and answer the question. If you do use drug-coated balloon, and they defined the use to be in what they call the target lesion. So if you define your target lesion and you use a drug-coated balloon in that area, what is the target lesion primary patency? But also asking the question, what is the access patency after you've used the drug-coated balloon angioplasty? And this was checked at 3 months, 6 months, 12 months, and 24 months. And then, were there any adverse events when we used drug-coated balloons in this application? Was the access abandoned at any time? Was also one of the secondary endpoints. So what lesions were included? They included lesions all the way from anastomosis to the cephalic arch. Immature fistulas that have not been used for dialysis were not included in the study. So these were fistulae with some clinical indication of a dysfunctional fistula, whether the KTOV was low, whether there was high venous pressures, whether there was low access flows measured on dialysis access, on dialysis circuits. The length of the lesion had to be less than 10 centimeters. The diameter maximum of that balloon that could be used was 12 millimeters, so the lesions had to be within that size, and there had to be at least a 50% stenosis. No central lesions were included in the study. They did not include any access that were thrombosed, and if you had a stent and a stenosis, those were also excluded from that trial. No grafts were studied in this study. So if you only look at the target lesion primary patency and look at 30 days, there was pretty much the conventional versus the drug-eluting balloon did not have any difference. At 90 days, 3 months, also there is no difference. At 180 days, there was a not statistically significant difference between the drug-eluting balloons showed a little better patency at the target lesions compared to the conventional angioplasty, and at 210 days it was statistically significant. But if you look at what happened to the access circuit, so you did this angioplasty today, and 6 months later, and almost 210 days later, There was actually no difference at all. Patients came back for some other reason for angioplasty. The target lesion had a 30% less chance of being stenotic at 6 months, but the access had some other problem that needed some work done in that period of time. So this is just a summary of what I just said. About 285 total fistulas, 140 in each arm, 71% patency with paclitaxel drug-coated balloon versus 63% patency with an uncoated balloon. About a 30% improved result, not statistically significant at 180 days, but these patients were followed for a longer period of time, and there were some improved outcomes at that point. They are still looking at this data. They're looking to publish a 2-year follow-up on these to see if there is a further benefit. So we wrote an editorial about the use of this, and this is kind of the summary, I believe, of what drug-coated balloon technology has to offer in AV access. I think AV access is a very challenging circuit. The stenosis is very different in different locations. A swing site stenosis versus a cephalic arch stenosis versus the body of the fistula stenosis could be very different. The body of the fistula could be a lot of neointimal hyperplastic tissue, or it could be because of posterior injury and there is a lot of compression from the back. It could be because of the hemodynamic factors are very different in different circuit areas that you're applying this balloon. So I think we really have to closely look at what lesion, which area would benefit the most in terms of use of the drug-coated balloon. And then there are several differences in the drug-coated balloon technology. What drug is being put out, what is the dose of the drug that is put out, and I think these are just very early days where the Lutonix balloon that was used in this randomized control trial, drug delivery was about 2 micrograms per millimeter square. Now this could be very different with other balloons. It could be different with other drugs that can be used in that form. And then just recently there's been a lot of news about using drug-coated balloons in arterial world, where a meta-analysis showed that patients who have had any drug-coated balloon application had an increased mortality risk. Now that really raised a lot of red flags. The FDA has been tasked with trying to go back to look at that safety signal, look at the primary data from all of those studies that have been done to see if there is really an increased risk of mortality by even one application of drug-coated balloon at any period of time. The jury is still out. We really don't have any good answer. The FDA, on a statement in June, I believe said that they're looking at that primary data to figure out whether this is really significant or not. Having said that, there are still a lot of trials in progress right now, which are trying to answer that question, whether drug-coated balloon technology can help us lower the risk of that restenosis that we've been all struggling to conquer over. There are studies all over the world which are trying to answer that question. And then, like I said, there are other technologies that are being developed. This particular technology is looking at rapamycin and instead of paclitaxel. So again, delivery of the drug can be different. The amount of drug that is delivered could be different. And the lesion that it is delivered to could be different too. We've used about 50 plus drug-coated balloons since 2018. We've not had any significant safety incidents. We've used it in different locations, mostly in fistulas, some in stent restenosis, because I believe that is a very frequent cause, a site of restenosis in some of our patients. And we primarily use in patients who've had restenosis after the first instance. So this is one of the example of a patient who got angioplasty in 2017. Good results, came back again with angioplasty in 2017, good results, but the stenosis is recurrent. Every 3 months it's coming back. And this particular patient had an angioplasty with a drug-coated balloon, and the interval of restenosis, which used to be somewhere between 50 to 100 days after that last angioplasty, is almost 575 days. So, and we've not had this patient come back since that one application of drug-coated angioplasty. So and then we've had some of those patients who had juxta-anastomotic lesions that have been intervened with the drug-coated technology. This was a patient who's got a stent, and there's stenosis right at the stent, and we've applied that, and this patient has had good results and has not come back for almost 300 days after that drug-coated balloon angioplasty, when they were getting recurrent angioplasties with a conventional balloon almost on an average 3 to 5 months before that. So in summary, I think this is early days for use of drug-coated balloons in dialysis access. The access circuit primary patency, I think, is the most important endpoint in terms of the life of the access. Does that get better? Are we using that fistulae for a longer period of time? Which stenosis would benefit the most? Which application will have the most benefit, not only in terms of prevention of restenosis, but also prolonging the life of that access is a big question out there. And then I think there are different options in which the drug is delivered. So like I said, more work needs to be done on this area. But I think some of the earlier signals that are coming are encouraging, and hopefully we'll find a better way of solving the problem of restenosis in dialysis access. Thank you so much, and I'll take any questions.